Hi, my name is Marjorie Erdmann, and I work for Oklahoma State University's Center for Health Systems Innovation. I'm presenting to you some research that we did at our center, which is estimating a rural-urban PCP workload disparity caring for smokers. Rural-urban population differences are sometimes dismissed as not that much, and in this case, we look at smokers where the difference is 3.4%. However, in these populations, the differences translate into PCP workload disparities, and we find that that is understudied. In the study, we leveraged the Cerner Health Facts data to estimate workload disparities that physicians face in rural versus urban settings. We contribute to workforce disparity research in two ways: by using 7.5 million unique patients that are identified as smokers and their medical records to accurately estimate chronic disease rate differences, and by using the number of chronic diseases to manage as the definition of workload. Let's start by walking through my poster. In the background, it's just the CDC estimates that there's this 3.4% difference between rural and urban. We hypothesize that the difference in workload is going to be much greater than 3.4%. And we argue that counting comorbidities is really salient in these given times because payers are associating chronic disease management metrics to payment. And so calculating primary workload by comorbidities rather than by just patient population really better captures what is considered a physician workload. Let me walk you through the methods. So to introduce you to the Cerner data is a health facts data warehouse that has about 200 hospital systems in it, 800 hospitals across the United States who voluntarily give their data to Cerner, who de-identifies it. We're one of the universities that receives the data, and I think we may be one of the only universities that receives all of their data. We can extract from that data smoking patients. So we use these codes to extract smoking patients and ended up with about 7.7 million, I'm sorry. Over here, it tells you that 1.3 are rural located patients and urban is 6.4 million. So what did we do with these patients that we extracted? Well, we counted their comorbidities. So we were able to do that, which is very difficult, but because the ICD-9 and 10 codes are so granular, we use clinical classification software to aggregate the codes into relatively high-level disease states. For example, my colleague Zhuqi explains that malignant neoplasms at different locations of the esophagus can be put together by CCS as cancers of the esophagus. Therefore, we can count disease states at a much higher level. So these are high-level chronic disease states that we calculated. We then looked at the urban population and the rural population and determined rates of comorbidities. How many had 0, 1, 2, 3, and 4. What's interesting about these two pie graphs is often the attitude when you look at them is the difference doesn't seem to be that much. It's not that much difference between these two images. However, when we really do the estimation, we start with assuming that both an urban PCP and an urban PCP treat 2,500 patients in their panel. We estimate, based on the CDC rates, how many does that mean for rural and urban doctors. And we estimate 712.5 in a rural, 627.5 in an urban practice. This already creates a disparity between just the sheer number. But then we look at the rates of comorbidities amongst those and apply the rates to that calculated number. And then we total how many comorbidities each one had. And I give this example. So of the 712.5, 14.73% of them had 3 comorbidities. That would equal 314 85 comorbidities. Just to show you up here, that number came from the rate of rural having 3 comorbidities. What we find in the results is by using the 2,500 patients in the panel again, we find that rural has 85 more smokers. So this is where the rural burden starts to cascade. It's a 13.5% increase over urban, And then we look at the rate differences of the comorbidities and find that it's almost 16% greater. So there's 320 more comorbidities amongst smokers that are in a rural practice. So while the 3.5 rural urban smoking rate difference doesn't seem to be that much, we think it really falls short of telling the story of how smokers likely impact physician workload differently in rural and urban practices. And we estimate that the smoker-associated physician workload disparity is around 16% greater for rural than urban practice. This is a sizable workload disparity, and we encourage the review of other patient populations to better understand the sources and how rural primary care workload becomes inflated. A limitation of this study is that the patients themselves are not designated as rural or urban in the data, but rather healthcare setting was designated as rural and urban. However, given that physicians themselves are rural or urban located, we found the use of the setting designation in the data to be valid in its application to rural urban primary care workload comparison. In closing, again, we would like to acknowledge the Cerner Corporation for sharing the HealthFacts EHR data warehouse. Any opinions, findings, and conclusions or recommendations are the opinions of these authors and not necessarily Cerner Corporation. And we'd like to acknowledge that this deep dive into our data to really understand rural patients was supported by a medical quality for rural areas by Pfizer Incorporated. It was a CHSI Pfizer joint project. And we appreciate their support of our work. I look forward to hearing any questions that you have. And I thank you for taking the time for listening. Thank you for learning about our estimation of a rural urban PCP workload disparity caring for smokers.